Welcome back to the Masterclass Coders. I'm Harshal, and in today's Explainer, part 6 of our series, we're diving deep into STEMI versus NSTEMI. We're talking ECG signatures, occlusion dynamics, and those tricky evolution guidelines. So let's jump right in and seamlessly bridge that gap between the clinical pathophysiology, what's physically happening in the heart, and the exact ICD-10-CM coding rules you need to know.
Here's our game plan for this highly focused session. We'll start with the anatomy of an infarction, hit the diagnostic workup, tackle the core codes, review subsequent MI rules, and finally, put it all to the test with some real-world coding scenarios.
Section 1, Anatomy of an Infarction. Let's get our clinical baseline set. To get the coding right, you absolutely have to know what's physically happening inside the patient's arteries first. At its core, an MI is defined by irreversible cell death, literally necrosis of the tissue. And this happens because of prolonged ischemia, meaning a severe lack of blood flow and oxygen. Picture a clot completely choking off that oxygen supply. That's what leads directly to the localized necrosis we're trying to code.
Now, the occlusion dynamics differ greatly between our two primary types of MI. On the left here, look at the type 1 MI. This is a spontaneous primary event, usually a plaque rupture or erosion. If that creates a complete occlusive thrombus, it causes transmural ischemia, meaning it damages the entire thickness of the heart wall. But on the right, you have a type 2 MI. This one is secondary to an ischemic imbalance. Think severe vasospasm, massive blood loss causing anemia, or extreme hypotension without any spontaneous plaque rupture.
Moving right along to Section 2, Diagnostic Workup. Before we even open a codebook, we have to rely on the diagnostic truths in the chart. The essential workup heavily features the 12-lead ECG and critical cardiac enzymes, especially troponin I, which confirms that cell necrosis we just talked about. When you're looking at that ECG, you're tracking the waveform, the P wave, the QRS complex, the ST segment, and the T wave. An ST segment elevation, boom, that's a STEMI. But if you see ST depression, T wave inversion, or just non-elevation, that points us toward an NSTEMI, where the ischemia is subendocardial. It hasn't breached the full thickness of the wall.
Which brings us to Section 3, STEMI versus NSTEMI codes.
This table right here, it's your holy grail. Notice how type 1 STEMIs route straight to the I21.0 through I21.3 subcategories, while your type 1 NSTEMIs map directly to category I21.4. But listen up, because here is a massive trap coders fall into: the official guidelines for evolution and conversion. The evolution rule says that if a type 1 NSTEMI evolves into a STEMI during the encounter, you assign the STEMI code. Period. On the flip side, the conversion rule states that if a patient comes in with a type 1 STEMI and it converts to an NSTEMI because of thrombolytic therapy or medical intervention, it is still coded as a STEMI. Just remember, once a STEMI, always a STEMI for that episode of care.
Let's hit Section 4, Subsequent MI rules, because timelines can and will get complicated. What happens when a patient suffers another MI while still in a healing phase of the first one? Well, according to official guidelines, if a subsequent MI occurs within 4 weeks, that's exactly 28 days of the initial event, you have to use a code from category I22. If this happens during the same admission, you sequence the initial I21 code first as your principal diagnosis, followed by the I22 subsequent code as your secondary. All right, Section 5, Clinical Coding Scenarios. Let's put this logic to the test. Picture this real-world scenario. A patient is admitted with a STEMI of the left main coronary artery. A week later, while they're still in the hospital, they suffer a completely new anterolateral STEMI. How are we sequencing this? You apply that 4-week rule perfectly, since the reason for admission was the initial event. Your principal diagnosis is I21.01 for the left main STEMI. Your secondary diagnosis is I22.0 for the subsequent anterior wall event that happened during the stay. Pretty straightforward, right? Now, what about facility transfers? A patient is admitted to community hospital with an acute anterolateral wall STEMI, gets transferred to University Hospital for a 2-day procedure, and then is sent back to community hospital for 4 days to recover. Does the code change across those 3 distinct admissions? The answer is absolutely no. You report I220.09 uniformly across all 3 encounters. Even with the transfers, it's all considered the initial episode of care for that specific infarction, since it's actively being treated and remains within that 4-week window. Let's throw a wrench into it. What if that exact same patient gets discharged, goes home, but is readmitted a week later with severe chest pain and diagnosed with a brand new inferior wall MI? What is your principal diagnosis now? because the actual reason for this brand new admission is the subsequent infarction. I-22.1 flips to become your principal diagnosis. You then follow it up with I-21.09 as the secondary diagnosis. That tells the whole story. The patient had a new event, but they are still inside the 4-week healing time frame of the original anterior wall MI. Okay, let's lock this in with a quick 30-second recap. Myocardial infarction always requires irreversible cell necrosis. Your clinical truth comes straight from the ECG and troponin I markers. Remember your code blocks, I-21.0 through I-21.3 for your type 1 STEMIs and I-21.4 for your type 1 NSTEMIs. Keep those evolution and conversion rules top of mind. And finally, any subsequent MI within 4 weeks triggers those strict I-22 sequencing guidelines, depending on the admission circumstances.
You now have the exact clinical logic to confidently sequence these encounters. Remember, a single missequenced digit doesn't just impact a facility's revenue cycle, it permanently alters a patient's documented medical history. So are your charts telling the true clinical story? Decode Healthcare with Harshal.